Thank you very much for a wonderful lecture. Just I want to start my lecture. Okay, my lecture is a bit different from my usual, just like technique of the aneurysm surgery. So this is a picture of the Professor Yasajiro. He attended the Hong Kong meeting. He told us the younger generation, very energetic as usual. And this is quite almost 20 years back. The Professor Kano, that he invited Professor Yasajiro, and also, yes, so Professor Yasajiro, he came to our department, and he taught us fibro dissection. So before the dissection, he taught us so many point. So this was almost more than 20 years back. Professor Sano and all department colleagues and Professor Kano, and we did the fibro dissection, followed by good lectures, so many professors. Thank you very much for every chance. And this is just, I want to say thank you very much, Professor Ivan Cannon, and also Professor Spanish. So they are always the teacher. And this is the video which we always we were a good team.
This is actually
and also the interact among the young doctors is very, very important. So maybe in at least next year that we should restart. So just before I start my lecture, I want to just a little bit a few slides about how we can teach and how we can how we can educate young doctors during this COVID-19. So the many young doctors decrease in their hands-on surgical experience and certainly in their career advancement. So just consider developing online learning modules and setting up simulation laboratories. But all these things is to allow the trainees to systematically acquire knowledge and develop the practical skills during these challenging times. So when we can start the face-to-face educational activities. So one is the recent travel restriction, but the new Center for Disease Control has issued new guidelines for vaccinated people can gather in a person enclosed space where the person meeting will take place. So today, I want to discuss with all of you about aneurysmal pathology. So many times I use these slides. So this is how we can treat, how we can judge we should treat or untreat for unruptured the aneurysm. So if the aneurysm size is the bigger, it has the chance of the rupture is almost 1/3. And the location of the aneurysm is ICPC and ACOM is easy to be ruptured. And also the aneurysm has a daughter sac, so may have a chance to rupture. So another our research work is the CFD and the weak point detection. So this is it has some rules. So this is a vector. So this is a conversion, and this is diversion, and this is a wheel, and this is the spiral, and this is fountain-like. So when we check the before surgery, we check all these such kind of the 4 or 5 factors. This is a vector, this is a streamline, and this is a pressure, and this is a wall shear stress. So we finalize of this part can be the very thin. we can estimate it before surgery. So this is a synchronized image. And also one more factor is OSI. So this is just a directional change of the wall stress during the cardiac cycles. So if the OSI is high, it can be that part is maybe the thick wall. And even we can apply this technique for endovascular. This is flow dynamic stimulation in IC2 large aneurysm. This is a before stenting. So after stenting, how change of the aneurysm flow inside. So this is a very small, tiny aneurysm, which is very close to the base. But actually, this small size of aneurysm, the wall is very thin. So this is a four factor: streamline and the vector, and the wall pressure, and wall shear stress. So this is a schematic drawing for young doctors, and this is how we can treat. So just we can remove of the endocrine process by a Lonju. And also meningo orbital band is cut it. Then we can go further down the drilling, the endocrine process. Then after that, we open the dura towards to the second nerve. So this is already we can see the IC and the drill of the endocrine process, the further down. So we estimated the location of the aneurysm just beneath the dura. Already we can see the aneurysm here. So this the aneurysm is the wall is very thin. So we cannot judge only the size of the aneurysm. So this is ICG. The wall is very thin, so very ICG is remarkable detection. Then we put the aneurysm clip. So this is another case for the prediction. So this is a 44 years old lady. So recently we superimposed of such a CFD of the 3D CT image. So we can estimate which part if the aneurysm is thin and thick. And after the removal of the endocrine process, then we can, this is just the usual, the ICPC aneurysm. So, but such a overlapping the image maybe sometimes help us. So this is IC ophthalmic, the aneurysm. This is a before and the after surgery. "68-year-old female. So this is a preoperative 3D CT that we can see the aneurysm here. So these CFD image tell us normal the aneurysm wall. So again, crinoidectomy. And here is the aneurysm. And we can see the ophthalmic arteries here, and this is second nerve. So this is isophthalmic, and this is again this is ICPC, but this is a very common site. So this is a 47-year-old lady. So sometimes the aneurysm became a little bit larger. So that this is anterocoidal artery is the severe adhesive on the aneurysm wall. And this is endoscopic. We can now is a check of the perforators come from the ECOM. After temporary clip, we further dissection. And this is the PCOM, and this is the perforators from the PCOM. And finally, we place the clip. Some part is very thin of the aneurysm. So, but we cannot exclude of the aneurysm from the circulation with just one clip. So we add the two more clips. So this is the PCOM and the perforators, and that is and one more additional clip. The best way is the first one should be the circulated encircled clip, and the second one come to the covered of the penetrated part. So this is just we can check the aneurysm wall continuing. This the seam wall, the mural generation with the seam wall, the thick wall with atherogenic changes. The aneurysm has a two part. So this is a CFD before surgery. This is a very high pressure, and this is a diversion of the vector. So change in the wall pressure that lead to the development of the mural degeneration. That means that this part can be the very thin. So just we can check the pathological the pathology and the monocyte inflated and also the demonstrated the CD68. And this is another case. The MCA is a small one, but the wall can be the very thick. So this is the fibrous thickening of intima. So this is seen by the elastic function. And also this is smooth muscle fibers. It's very thick of the aneurysm wall. So these histopathological findings suggest that this part of the aneurysm wall was completely stabilized due to remodeling. So this is our strategy. So this is the first hit place. Then this can be the development of the circulation flow is the next one. Then this part become remodeling, become very thick. And this next part is again the new blade, the development. So this is our concept, how the enlargement of the aneurysm. And this is again is a three component: the mural degeneration, and also the macrophage infiltration, neovascularization, the microbleeds, the thrombus in wall, and the thrombus progression in intraluminary. So this is a mechanism of aneurysm growth. So pathogenesis is a molecular mechanism, is occurrence, development, and rupture. The formation of the aneurysm initiated in response to the excessive hemodynamic stress to intracranial arterial wall of the vascular bifurcation, and the hemodynamic stress and the inflammatory reaction by macrophage and the vascular smooth muscle cell death, crucial for the formation of the cerebral aneurysm. And also this is some the role of the nuclear, the factor kappa P and the mediate monocyte chemotactic protein 1. So this is the paper from Professor Aoki from the Kyoto University. And if the aneurysm is the rupture one is a massive inflammatory cell invasion we can recognize. So this is steps. This is prostaglandin related. And anyway, the long-lasting chronic inflammation of the growing of the aneurysm factors. And also this is research work. Again, this is the macrophage, some relation with enlargement of the aneurysm. And this is, again, the macrophage cause endothelial disruption. This is a paper from the Koseki from Japanese one. And also the wall pathogenesis, sorry. Giant aneurysm. One is vasovasorum pathway. Already I mentioned many times. And this is the case which I showed many times. This is many times treated by endovascular surgeon. The stent with coil, many times. So this is finally we did the surgery because of the aneurysm compressed medulla, and the patient became some symptoms. Just you can see the aneurysm wall. This is very large of the vasovasorum. So aneurysm became more than 2 centimeters with a partial thrombus. And this is through the cranial nerves. And after we check the proximal distal of the aneurysm VA, and we cut the aneurysm after the proximal clip. So it is a very good case, I think. Even the stent with coil, but still the aneurysm became growing. And once we open the sac, some bleeding is coming from. So this is a vasovasorum is the main cause of the regrowing of the aneurysm. So this is a vasovasorum. And this is another case. This is a vascular trunk, the aneurysm, the large one. And this is so this is the angio. So this is the recirculation flow with area of the stagnation. So this part can be the thick. So the other part can be the same, we estimated. So this part is a diversion of the vector. So can be the very thin part. This is diversion part. So multiple area with high oscillative wall shear stress representing change in the flow or direction. So this is precipitate approach. So this is a fifth nerve. And already we can see the aneurysm sac. And then as aneurysm sac, most of the sac is rather tough. And that is SCA. So for this case, we try to the 3 clips. So this yellow part is a vascular trunk. So this is an endoscopic view. So this is the aneurysm. And also this is ICG. So we can check the flow in the aneurysm sac. So then we place the aneurysm clip. Finally, we apply the 3 clips. So this endoscopic view, and yellow part is a vascular trunk. So just we can estimate which part is the thin and the thick part of the aneurysm before the aneurysm surgery. So this is the kind of the summary of such kind of the large or giant aneurysm. So vessel wall disease, this is a no more giant aneurysm. So because of the vasovasorum, this is one of the cause of the growing of the aneurysm. So different pathomechanisms should be treated, the different treatment strategy we need to check. So this is the MRI. This is the 4-grade ABCD. So this is enhancement of the aneurysm wall. So if the aneurysm has enhanced, the wall should be the one of the factor of the easy to be ruptured in the future. So this is kind of to discriminate between the stable and the unstable the aneurysm with the enhanced aneurysm wall of the MRI. So this is an image which we can tell this is enhanced aneurysm wall and also the basal formation and the inflammation. And also higher wall shear stress. So these three is very important factors. And also the aneurysm wall, like a CFD and MRI enhancement of the is very important factors. So preemptive medicine can be established with specified biomarker and imaging modalities to prevent or the weaken onset of the symptoms of the cerebral aneurysm. So future target therapy, of course, the open or endovascular flow diverter, etc., is very, very important. But another thinking way, the role of anti-inflammatory drug or anti-angiogenesis strategies or new treatment strategies, vascular remodeling and inflammatory through inhibition of the MMPs or other cytokines may be offered how we can treat of the aneurysm in the future. Thank you very much.
Thank you, Professor Kato. This is another testimony that we are not only technical, but we are moving into the basic science of aneurysm. And this is a very good in the future evolution. I think we have 1 minute for comment. If somebody wants to add a comment on this evolution, whether it's ICG, flow measurements, and endoscopic. I'm sure Dr. Dorrance enjoyed what he has seen. That time they didn't have these facilities. Do you want to give a comment, Vinko, on this evolution in aneurysm surgery?
Regarding the wall of the giant aneurysms and the biological and what is going on there, it's a wonderful study, and the aneurysm wall is growing actually, as it was shown, and there are reasons behind and why it is so. And for that reason, it is very, very useful to know what is going on in an aneurysm before you plan surgical intervention. This is a completely different issue, and you have to be prepared for any possible solution at surgery, not only for clipping, as I said before. So I can only congratulate Yoko.
Thank you.